Hi, I'm Dr. Greg Jica, professor of neurology at the University of Kentucky Alzheimer's Disease Center. I'm here today to talk a little bit about the consensus process that we use when reaching a ultimate diagnosis for our research participants. So the consensus process involves a lot more than just cognitive test data. And so this is a very busy slide, but it really just points out many of the different variables that we're collecting, and they all do come together in the consent process. So there are basic background and demographic information. A lot of this is collected by the psychometricians, the testers that interact the most during any clinical visit with our research participants. They may go over the subject's family history in addition to any other background that the patient may have in terms of their demographics and other associated scales. There are data collection instruments that are also given by that psychometrician or frequently a social worker if we're working with an impaired person, including assessment of neuropsychiatric symptoms, geriatric depression scales, and functional assessment scales. The clinical cognitive battery is then administered by the psychometrician, including a variety of different scales that test and challenge different brain functions in the areas of attention, executive function, language function, memory, and visuospatial function. And importantly, a clinician visits with each of our participants to review their health history, their medications, perform a physical examination, a CDR, a clinical dementia rating scale score, and a neurologic exam, including assessment of Parkinsonism through the UPDRS motor scale. Ultimately, all of these components come together in the consensus process. Of course, having operational criteria for your diagnoses are critically important. So we use clear-cut operational criteria according to the National Institute on Aging and Alzheimer's Association categorization of Alzheimer's type dementia. So cognitively intact individuals frequently are scoring greater than 1.5 standard deviations below their age and education adjusted norms. Now, frequently we do have to take into account baseline levels of cognitive function, and after a period of 2 to 3 years, once we have longitudinal data on an individual participant, this really becomes modified for an individual. So if someone starts out at 2 standard deviations above the mean and is currently functioning at the mean, they've lost 2 standard deviations, and that may well be a flag that they are developing some degree of impairment despite how they appear in normative samples. Our neuropsychologist will go into this in greater detail. A diagnosis of mild cognitive impairment requiring either a subject complaint that this is a change from past level of performance, or if we have seen them longitudinally over time, evidence for decline, 1.5 standard deviations as a general rule that can be bent at the discretion of the neuropsychologist, and of course, intact daily functions. Now, we've been challenged in the past with folks who have been diagnosed with mild cognitive impairment, frequently even with biomarker validation of an underlying degenerative process, who, when we start symptomatic medicines, cholinesterase inhibitors or partial glutamate antagonists, revert to normal on their cognitive testing. We still call them if they are under treatment and have had a past diagnosis of a degenerative type of mild cognitive impairment. Their diagnosis remains MCI despite overall generally normal cognitive scores. This is our assumption that this is a treatment effect rather than any effect on underlying disease process. And then, of course, dementia, impairment, as we see cognitively in our MCI folks, but also functional impairment that is disrupting their daily activities. And this can come out of interviews with the patients or from formalized scales such as the functional assessment questionnaire. We have a fourth category, and that is impaired other. And these may be folks who have normal cognition, but there are significant complaints or interference with daily activities that don't allow them to be fit into any of the previous classifications. Or they might have detectable cognitive impairment, but we feel that that may be primarily due to a non-degenerative or vascular cause. These folks frequently are watched, and over time it may become clear. This may apply to those that have cognitive impairment but are on high doses of anticholinergics or opiates, or it could apply to somebody who is cognitively impaired but is currently suffering from severe depression or other psychiatric symptomatology that may be non-degenerative in nature. We use a biopsychosocial diagnostic process, and that is each member, three different components to that: a tester, the psychometrician, possibly a social worker, commenting on the state of the participant when they underwent their cognitive testing, providing information to the neuropsychologist, providing study partner insights, relevant social and behavioral components that they've picked up during their assessments. The neuropsychologist doesn't actually sit with the patient or the study partner. They instead look at the objective cognitive test data in the context of age and education, normative values, and the relation of their test performance to anything that we may have in terms of longitudinal performance from past evaluations. The patterns of neuropsychological cognitive test impairment may provide some clues, and they may comment on underlying etiology. And lastly, the clinician incorporates any clinical considerations derived from the medical history, from the medications that the patient is on, and from their physical examination, ultimately deciding on the etiology. But the diagnosis of whether or not they're cognitively intact, have mild cognitive impairment, dementia, and or are impaired other is critically formed on the basis of discussion and agreement between these three components. So there are two possible outcomes of a consensus process. One, which we strive for, is when all three discussants are in agreement with the diagnosis. Thus, consensus is achieved and we can proceed to discussion of what we feel is the underlying etiology. Alternatively, there are many times when there is a lack of agreement between the three discussants, where one or more may feel that the subject is impaired, meeting criteria for MCI or dementia, or impaired other, and other members of that group feel that no, they're really not impaired, or that they may fit into one diagnostic category or the other. In these instances, we open a discussion. We apply our operational criteria to see if we can unify agreement. And if we can't reach agreement, this is an instance where we would use the impaired other category. We're really not sure. We couldn't get all components together. We try to use impaired other very sparingly, but it does come in handy in cases where the information derived from the three components or discussants in the consensus conference are simply at odds and cannot be resolved. I'd also like to talk a little bit about biomarkers. So we've learned over time the major sequence of pathologic events responsible for Alzheimer's disease. We know that amyloid accumulation is followed by cell injury, the development of abnormal tau inclusions, neurofibrillary tangles, impaired cellular function, neuronal loss and atrophy over time that only eventually leads to memory loss. And when that becomes significant enough, the functional impairment characteristic of a dementia. So we do use biomarkers, not for the consensus of are they normal MCI dementia or impaired other, but only when we get to the discussion of etiology. So there are two different types of biomarkers that we're using on a regular basis in consensus. One are validated biomarkers, biomarkers that clearly define a disease state. These might include MRI changes, FDG PET, amyloid PET, or CSF measures of amyloid and tau. We also incorporate in our consensus process other experimental biomarkers that are not yet definitive for an underlying disease state, but may help guide our diagnostic thinking in terms of etiology. Again, not using these to categorize patients as cognitively intact, MCI, dementia, or impaired other, but instead to stimulate scientific discussion. So our blood-based biomarkers could include Alzheimer type proteins or proteins involved in neurodegeneration, such as neurofilament light chain. They include an inflammatory and a vascular panel. We might see somebody where we have EEG data or retinal imaging or other biomarkers that have been collected. Again, we do not use these to determine etiology because they remain unproven as of yet, but they are food for thought and scientific discussion that can be an important part of the consensus process. So now let's move on and see how an actual consensus is conducted. This is a point where we'll break to the multiple segments, cases that we've captured during our consensus recordings. This is where we will place slides and or a discussion of the tester psychometrician's role in contributing to the consensus conference. This is where we will provide a video of Jordan Harp reviewing how he uses the objective cognitive test data to come up with his component of the consensus conference. And lastly, the role of the clinician in determining the biological impact of multiple factors and again, underlying etiology. So I function as an MD, as a clinician in the consensus conference, and when visiting with patients, I'm able to incorporate my clinical judgment regarding medical history, the medications that they're on. Those may be causative of memory problems or other cognitive issues, or they may be medications that are used to help improve those symptoms. The physical and neurologic examination, largely looking for focal deficits and or Parkinsonism that may help with underlying etiology, and of course, opinions on validated biomarker assessments. So let's move through these. Medical history, we're really looking at relevant risks and associated diagnoses. So medical causes for cognitive decline. Does the subject suffer from depression? Is that depression in the setting of Alzheimer's or another degenerative process, or is depression primary? Are there other psychiatric disturbances, sleep disorders, unstable chronic health conditions, chronic pain syndromes, psychosocial stressors, cancer that's active, vitamin deficiencies, endocrine or metabolic disturbances? Two examples here might be someone with untreated obstructive sleep apnea who is dozing on and off during their cognitive testing. That might be a medical reason for why the neuropsychologist marks impairment in their cognitive scales. We might see a subject with abnormal lab values suggesting underlying metabolic dysfunction that could interfere with cognitive test performance, such as a subject who comes in and on the day of testing has a blood glucose of 458. This may well be somebody who is not in the early stages of a degenerative process, but instead needs their medical problems corrected. We might also have associated diagnoses that are risk factors for MCI and dementia. These could include past stroke, Parkinsonism, traumatic brain injury, strong family history of dementia. So again, a few examples. We might have a subject who had a motor vehicle accident with traumatic brain injury, and following that event, began to experience cognitive decline. This is important to discuss during consensus. We might have a patient who has a history of several prior strokes, and even though their physical deficits have shown some recovery, they continue to have associated cognitive decline. Or example 3, somebody with a progressive history of Parkinsonism or Parkinson's disease might really elevate our index of suspicion for an underlying degenerative process. Medications, of course, we want to look at medications that might be causative of the cognitive decline. And really need to take these into account so we don't overcall dementia when it's really a result of inappropriate medications. We particularly are on the lookout for anticholinergics, benzodiazepines and other sedatives, opiates, but many other medications that can interfere with cognitive state. So as an example, somebody who comes in who's been placed on hydrocodone, an opiate at high dose multiple times per day. And that may be responsible for the decline that we're seeing. We might see somebody who comes in on oxybutynin, an anticholinergic, bladder antimuscarinic, and is taking Benadryl at night for sleep, diphenhydramine. And their overall anticholinergic burden could be creating the image of cognitive decline when there is no underlying degenerative process. The clinician will weigh in on these. Also, we look at therapeutic medications, whether or not folks are coming in on cholinesterase inhibitors, on memantine, antidepressants, anxiolytics, anti-Parkinsonian medications. They can be clues to underlying features of a degenerative disease that may not have become apparent through the history and other data collection instruments. So example 1, somebody with a past history of mild cognitive impairment. We started them on donepezil and now comes in with normal cognition. We don't think that their Alzheimer's or degenerative process reversed itself. Instead, we think that symptomatic improvement on these medications has changed their cognitive test scores. They remain mild cognitive impairment. We might see somebody who is on escitalopram, bupropion, and buspirone, and we know that severe depression and anxiety are major problems for this individual that might skew us away from a degenerative diagnosis and make us begin to think and at least consider whether or not an underlying psychiatric condition could be responsible for any cognitive change noted. The physical examination, of course, looking for respiratory, cardiac, GI, chronic pain issues, very, very important. So we might see, as an example one, somebody who comes in and we can see that they're in respiratory distress with shortness of breath, a pulse oximetry of 84%. On the pulmonary exam, crackles and rails throughout, and lower extremity edema. And we realize that they're in the midst of a congestive heart failure exacerbation, likely responsible for their decline in cognitive test scores. We might see, and I saw this just last week, with a patient who was obviously grimacing and at pain, even at rest from an orthopedic injury. Well, this person is clearly not going to perform at their optimal best on the cognitive testing, and the clinician can provide these insights. And then the neurologic examination, again, looking for focal deficits and or Parkinsonism that walks hand in hand with cognitive decline. So we might see a patient, we note on exam, with no report or past history of stroke, that there is right upper and lower extremity weakness and hyperreflexia, suggestive of a cerebral lesion. That requires a workup and evaluation in consideration in the consensus conference that might shift our diagnosis and or underlying etiology. We might see an example too, somebody who comes in with no diagnosis of Parkinson's, but we note that they have a resting tremor and a shuffling gait with a masked face. And we recognize, there is an underlying alpha-synucleinopathy, a Parkinsonian disorder that may be related to any cognitive decline seen on examination. We use the validated biomarker assessments. So this may be structural MRI, looking for patterns of focal atrophy, medial temporal lobe atrophy for Alzheimer's disease, frontal or temporal atrophy for FTD, ventricular enlargement for normal pressure hydrocephalus or other causes. The T2 images, FLAIR, SWI, DWI, might reveal extensive white matter disease, small vessel ischemic change, infarcts, hemorrhages that we need to take into consideration. FDG PET can show Alzheimer's versus FTD patterns or normal patterns of cerebral metabolism. Amyloid PET, visual and SUVR confirmation of elevated amyloid and CSF amyloid and tau levels. Rarely, we do have tau PET as well that can be brought into consensus conference. So that's an overview of how we proceed with a consensus conference. The evaluation with the patient incorporates 3 or 4 individuals, each collecting pieces of information. And again, the consensus is a time period where all those pieces are being brought together to see if we can reach agreement. And in doing so, we are much more certain that the diagnosis applied to an individual patient is accurately reflective of the underlying disease process that we're trying to diagnose and potentially treat for many of our patients. We hope this has been helpful for you all. And again, we thank you for your collaboration on this project and look forward to our continuing work together to standardize these processes across centers and across the globe.